Just quickly introduce myself. So I'm Paul Greenwood. I'm a program manager from AQUA. AQUA is an improvement organisation, and we do a lot of support into health and care organisations around any improvement activity. And from my particular point of view, least restrictive practice is a thing that I've been doing for some years now across the Northwest. So my background is as a registered mental nurse. So I've been 38 years working in the NHS and social care, and I've done a lot of work at a regional level, particularly around the Mental Health Act amendments in the early 2000s. And at the creation of the Mental Capacity Act, I was the implementation lead for the Northwest for that piece of legislation, and the deprivation of liberty safeguards, which kept me very busy for a few years. So that's me. I've also got Bridget with me. Bridget, just want to quickly say hello. And then...
Hi, everyone. My name's Bridget Welch. I'm one of the specialist safeguarding practitioners working with the ICB, and I tried to support Paul, or hope I supported Paul throughout the project.
Thank you, Bridget. You did indeed support me. This is a slide at time. I'm not going to go into this because we haven't got the time, but it just tells you a little bit more about what AQUA do, and you can look at this in your own time. But really, just this in this 1 hour, hopefully, I'm going to get across some of the foundational things around working in a least restrictive way, or if you're doing a project that's least restrictive, and some things that I've found with my learning that is really helpful in a variety of settings, whether it's in a secure mental health setting or it's in a home. Doesn't really matter. We tailor it to those different environments, and some things are the same across any of those environments as well. So I'm just going to do a bit around raising awareness around restrictive and least restrictive practice, a little bit around our improvement methodology, which is called quality improvement. Continuous improvement is the method, but really soft version of that. So rather than feel you've got to want a training course to know about it, it's how do you do it in a practical way, so you learn as you go along. And then understanding the impact of least restrictive practice can have, and that's where I'll talk about the project we've done with a number of care homes in Lancashire, and I'll feedback some of the staff impact, and also how that impacted on residents, and really how we can sustain least restrictive approaches. One of the biggest challenges for anywhere, because as we all know, is like you can easily do it, it's how do you keep it going, and that's the real challenge. So a little bit about what we're doing with the project and how we were looking to sustain some of this work. So in terms of some of the things that I think are foundational when you're looking at least restrictive practice is to start with kind of what do we mean by that? Because there are so many variables in people's views about what do we mean by least restrictive and what is restrictive as well. People have a variety of views on that, and I just want to sort of quickly talk about that in this session, just to give some clarity to that, because if you're not clear about what you mean by restrictive and least restrictive, you tend to find people might get the wrong end of the stick and go off and think that something that they're doing is fine when actually it isn't. The same is around when we talk about quality and what we actually mean by quality, and people all different views about what quality is. So I'm just going to quickly touch on that. The importance of that experience, the patient experience and the resident experience. The impact of the environment has on an individual, and how staff and residents or patients engage in that in different environments, and how that in itself can be quite restrictive. Talk a little bit about leadership and the importance of leadership as it drives change. And then one of the biggest for me is around being trauma informed. Some of these things you will already know, and this may be a bit of a refresh. So I'm going to just quickly go through this foundational stuff that is the content really of the project that we did with the care homes. And then I'll take you through how we did the project and what were the findings of that. So just in terms of questions, I'll do this first section and then we'll have a bit of a break for any questions. And again, Haley's we're watching the chat box. So if you've got any questions, drop them in there. And we'll deal with them in this first section. I'll then do the second bit, and then we'll do any questions before we bring it to a close. So when I talk about restrictive practice, over the years, I've had interesting things said to me about what people feel is restrictive. So a simple example is holding somebody. And I've had staff with views that holding somebody isn't restrictive, that holding somebody is just helping them, or it keeps them safe. And people attach meaning to that hold that is a kind of positive, appreciative meaning to it. But actually, a hold is a restriction. Even just touching somebody is restrictive. So sometimes people might put varying degrees of, oh, that's not restrictive because I'm not holding them as tight, when actually you're just holding them. That's it. So when you have a conversation with staff about what do we mean by restrictive, it's really important to draw out all those variables and then help people to make sense of, well, what do we actually mean as a team by this? And you can use some definitions that are already out there, and the standard definition is in the Mental Health Code of Practice from 2015, and that restricted a patient's movement, liberty, and/or freedom to act independently. And that can be anything from moving a person away from a door to holding a person because they become quite agitated and maybe waving their arms or lashing out, and you're holding them to restrict them hitting somebody. So there's a lot of, so you get teams to talk about what we mean by restrictive practice. And that can include, what restrictive practice do you do? How do we restrict each other as a team? How might residents and other residents restrict each other? How does the environment you work in, what restrictions do we place there? So chairs might be in a particular position which is not helpful and limits people's ability to move around. Doors might be locked when sometimes they don't need to be. So there's all this kind of thinking about the environment you work in and the way in which people behave. And the same can be said about quality. So when we talk about, oh, this is a real quality of intervention, what do we mean by that? Who's the quality for? Is it great for the staff, but actually it's of no value to the resident? So thinking about, when we talk about quality, and particularly when you're working in a team, and particularly in a multidisciplinary team, I just think about when you think about quality when we go shopping or we buy something or you're getting your hair cut or you're booking an appointment, whatever it might be in general life, we'll have a particular view about what's important to us. That I want good value for money. I love a bargain. These are things that to me are quality. For some people, they might say, well, I like luxury. I like it to be top end. So we have a different view on it. So think about and talk to your team about when we talk about quality, what do we mean by that? What does great quality look like in the context of the work we deliver? And it's really interesting what people come up with. But again, it helps the team to understand what we mean by quality and then start to implement some of those work, just like you would around least restrictive practice. So in those two areas, it's about being clear about what we mean by it. What does great quality look like when you interact with residents and their families? Again, being able to draw on residents and families about what does quality mean to them. And we know some families sometimes they might walk into an environment and think, oh, this isn't great, but actually the quality of the care in that environment is fantastic. Sometimes it's not just about the way a thing looks, it's about what's happening in that space. So sometimes being able to pull that information from families can really help better understand what does a quality intervention mean from a family's perspective or a resident's. And these all just add and help teams to think about what they need to do in that care setting. So when I talk about patient experience and engagement, and I saw this in the homes that I worked at, and I do see this a lot in the NHS and in inpatient settings where I've worked on least restrictive practice, is that sometimes we look to the end. So we look at a restriction that's happened. So, well, that's the outcome. A restriction has occurred. Well, it's happened now. But what about the journey? How did we end up in this position? How did we end up restraining this individual? How did we end up restricting this person? What's that journey been like? Where did we start with this? And I've used mobile phones, and Apple, for example, spent a lot of money on just a box, not the phone, but on the box, because they wanted the customer to have that experience, because customer starts with opening the box, seeing the object and then using it. So And for me, that ability from a patient experience point of view is to see it as a journey, not as a destination, so that the those little things, like just the box itself, and you know with an iPhone, you get a white box and it's all very beautiful, and it's all very simple, and when you open it, it's very slow to open. It all adds to the interest and the excitement. When we look at healthcare in the context of that, it's kind of what's that moment when you arrive at the front door? What's that kind of very early introductions? You've not received any treatment or care intervention necessarily. It's just somebody offering you a cup of tea, a smile, and all. So it's that kind of what's that journey like for that person, because that will dictate their experience. And if that's a good start to a journey, it's highly likely that there could be a good end to that part of the journey. And we saw that when we worked with the homes. So thinking about that kind of the people you care for, about what's the journey like for them, and what part do we play in that journey, and what are the bits that people are really happy with and really engage with and are curious about and are interested in, and what are the bits are they not. And we think about mobile phones, and when you get to the using it bit, there are lots of things on a mobile phone we do not use. Probably 80% of a mobile phone, we just never use a lot of the stuff on it. We know what we want from it. So it's not really about the mobile phone, it's about that sense of the journey again. So when I think about quality interactions, and this is some work we did with the teams that we work with on the project, was getting them to think about what makes up a quality interaction. Are they personalized? And do they recognize, and for those of you who are aware of Kate Wood, about personhood, did they, particularly with people with dementia, is that sometimes we can end up taking their personality away from them. We end up turning them into a diagnosis. And there's something about going back to basics again, and some of those, what are the things that make us tick as human beings? And one of the teams I work with, we talked about what love means and what love means to you. And that could be about the love of your family, friends, your relationships, your love of gardening, your love of whatever it might be. But then what do the people you care for, what does love mean to them? And that might be just holding your hand and going for a walk down the corridor is something that's really important to them, that sense of touch, that sense of being around people, and again, that sense of family. And sometimes the processes that dictate our days can suddenly distill that sense of humanness and that sense of love. And it sometimes feels a bit of an odd conversation to have with the team about, let's talk about love. But actually, it's really important because it's a common theme amongst every human being, and something that I think teams can have play around with as well, in terms of thinking about what love means to them is not that different than what it means to the very people they're caring for. And I think it brings you closer to that human connection that you can have with somebody, rather than sometimes it feeling transactional. To be kind and compassionate, open and honest, respectful, and to feel valued. And they're kind of common sense things, really. Nobody could argue with them. But those interactions also need to be safe, and that people need to feel safe, that they need to be done in a timely way, that they need to be supportive, effective, and efficient. And I say that, I think those things because sometimes, say a resident may want something, but we end up having to be dragged off to do something else. And it may be an hour later by the time we get back to that person, at which point that's not been a quality interaction for that individual because it wasn't timely. It wasn't effective because you said you'd do something, then you got dragged off to something else. And I've done it myself as a nurse where we forget that we've said to somebody, I'll be a minute. When you're doing personal care for somebody, sometimes you've not prepped enough and you've had to leave the room to go and get something else. That can be really disruptive. And all of these things about being safe, timely, supportive, effective, and efficient, and being more personalised, other things to me are all about being least restrictive. That you're not having to think about holding somebody because actually you're doing the things that matter to that individual that you're caring for, because it's about them. So when I do when I'm doing the care on projects, the environment was really important, and in any least restrictive work, it's really important to understand how the environment impacts upon the way you work, the way the people move around in it, how care is given. So we talk a lot, and I talk a lot in the project about thinking about like a walk around. So if staff just do walk arounds but do a walk around as if they are a resident who lives there, and actually what do they see? Thinking about using their five senses. What do they hear, see, touch, smell, and taste? That sense of orientation, that are the defined spaces where people know that that's where I sleep, that's where I eat, that's where I play. These are exits and entrances, and these are corridors. And are those distractions that are around things like colours, light, sound, smell, and touch? So, for example, one of the homes had a very long corridor, which was Magnolia. And it's a male unit, dementia plus unit. And the men would walk up and down this very long corridor, but it took them nowhere except to a closed door. And they were generally halfway down that corridor, they would end up urinating. So you would end up with this awful situation of there was nowhere to sit. The men would set off walking, but there's nowhere to go. And then halfway back, they'd realise they want the toilet, but there was no toilet on that corridor, no signs anywhere, and it was all one colour. So it just felt like lots of incidents were occurring because there was nothing to orientate people to where they were at. And it was and the colours were not helpful. There were people who were quite disorientated. So it was about breaking up those spaces so they felt more defined and that people knew where they were. People know when they're at a dining room table, or people know when they're in a lounge or when they're in a garden. But as staff, think about the impact of that space and how it affects the people you care for. And think about when you've had a walk around and felt that, what could you do differently? What were the things you picked up? And you might be 25 years of age and be very energetic, but you might be caring for somebody who's in their 80s. And that person, you need to put yourself in their shoes to say, what would it be like for them? Their vision might not be great. So how do they know where their bedroom is? Is there anything that defines that space for that individual to make them feel that they're in control? Even when somebody's got dementia, they're still aware of what those spaces are. And a very quick example is when people put, particularly in dementia spaces, where people put wallpaper up that's got books, fake books on it, like fake book wallpaper. You can see residents sometimes grabbing at the wallpaper because they think it's a book. All that does is agitate people because it's not really a book, but you think it's a book. So you can see that sometimes those kind of distractions can actually cause more agitation. So sometimes it's, if you're going to do books, do real books, put books that they can read on shelves. And then there's informal leadership. So when we talk about informal leaders, and there are formal leaders, and these are our senior managers, and they are given management responsibilities, and they need to be the ones who drive change. But in every team, everyone's a leader and everyone's an informal leader. And there are some informal leaders, and you'll know people who you work with or have worked with over the years who model great care. And these are people who influence the way you care. These people can model compassion, respect, and great listening skills. They're people who provide great feedback to colleagues, whether it's good or not so good. And they can make suggestions. And think about, what is that leader doing in that informal leadership style that actually can really influence a team and influence the culture, and what really works well, because those informal leaders have quite a lot of power, and can really help change a team more so than some of the senior leaders, because an informal leader who's very strong can be a carer or a healthcare assistant or a support worker. They don't have to be a qualified member of that team, because they're just great at modelling certain behaviours that work really well, and residents and patients respond really positively to that. But with leadership comes power, and with power comes rules. And I see a lot of a kind of assumed authority, that now the manager's gone, we're in charge, so this is how we'll do it, because it works for that particular team. And that can again lead to negative impacts on the people you're caring for. So sometimes that assumed authority can lead to what I call lots of rules being created. And these are called unwritten rules. And every team has got unwritten rules. There'll be somebody in your team who likes a particular thing doing a particular way. And that works really well for them, but it doesn't necessarily work for their colleagues, and it might not work for the people you care for. And I've seen some really bizarre rules over the years that have just been created. And the team I work in at the moment, there are some unwritten rules, and there are unwritten rules that I've got now, and I have to constantly check myself that might work for me, but it doesn't necessarily work for everybody else. And then there are just habits that are created, and some of these habits become rules, like no toast after 9 a.m. or you can't do this at a certain time, or you can't do that. Well, who says so? Where's this rule come from? Is it a policy? So sometimes it's really worth having a look at what actually are the unwritten rules in your teams, and then start to think about, is this rule really of any value? Is this rule helpful in how it keeps people safe and secure? Does it align to policy? Is it guidance? Is it a national or organizational thing? Is it least restrictive? And is it fair and equitable? Because if it's none of those things, why are you doing it? So there's something about sometimes these rules appear and they disappear. So sometimes it's having an open conversation with the team to find out what rules are around, what rules exist, and are they the right rules that ensure that people can live in the least restrictive environment and still feel safe, still feel valued, and that it's fair and it's equitable. And finally, just in this section, I just want to quickly talk about trauma-informed care. And again, some of you may know about this, but there's the definition, which is about and for me, trauma is something, and particularly mental health, when I started doing this about 10 years back, 10 plus years ago, that trauma was not a word ever used. But actually, it's kind of fundamental to the very people we care for, because it's something that we may all have experienced, some level of trauma. Some people experience it more than others. And thinking about the impact that a traumatic event can have on an individual can shape the rest of their lives, particularly if that is systemic. So for me, there's something really helpful around being trauma informed, because if you're trauma informed, you're personalized in the way you care for people. And there are 6 principles to that. One is safety, trustworthiness, peer support, collaboration, that patient voice, and I include staff voice in that, and that cultural, historical, and gender issues. So that really understanding both where you're coming from, where the patient come from, who is this person in front of you that I'm caring for? What makes them tick? Who are they? And part of being trauma informed is that realizing that trauma exists, recognizing some of the symptoms of that and the signs of it, being able to respond in a positive, appreciative way to that, and to avoid re-traumatizing somebody. And a very simple example is, and I've seen this a lot in female mental health units, to be honest, is that sadly for many women in those environments, they have had a history of abuse, sexual abuse or domestic violence. And yet they end up in situations in a closed environment, a locked environment, where they may end up being restrained by male staff. And that's just a re-traumatizing situation for that particular female. So there's something about how do we seek to avoid that? Because if somebody's being cared for, we want to do the right thing. We want to aid recovery. We don't want to re-traumatize people and delay that recovery. So just thinking about trauma, is that psychological trauma of, is it situational? Is it a one-off incident like a bereavement or a car accident, for example? Or it may be something that has been experienced over time, and we call that relational trauma. And there's that thing about you can experience it as a witness as well. You don't have to have been there. And also staff experience trauma, and you can experience trauma just by caring for people, because you are listening to sometimes quite distressing stories or experiencing quite distressing situations. So it's important to think about yourself as well. So those are the things for me that are foundational when looking at being least restrictive. And I'm just gonna, just list the kind of things that it might help you think about. So before I move into the project, are there any questions on anything what I've just gone through? Is there anything in the chat box?
We haven't got anything on the chat or the Q&A at the moment. Does anybody want to put anything on there? at all. Just on that last point, while we're just, if anybody wants to just give people a chance to put anything on, Paul, is there, you
Yeah.
said about, from a staff experiencing trauma because of just by caring for people.
Yeah.
What sort of support have you found that's available to help with that?
What I find is that people can do for themselves is that you put debriefs in there. If there's been an incident happen, that's got that ripple effect where it affects not just one person, but it can affect the team and the organisation. Then I think it's really important that there are safe spaces for staff to be able to debrief about that instance. So if there's been a death in a home, for example, there's a relationship there that member of staff had. So there's something about how do we create safe spaces for staff to be able to debrief about that, but also how do we ensure we have policies and procedures that keep staff psychologically safe so that they're able to talk out and feel safe to say, I don't think this is right, I don't think this is right. For me, with the projects, what I found was a kind of organisational trauma, really, was sometimes people's experiences of a CQC visit, that it can really impact morale. And sometimes where's that space for those staff to say it felt unfair, or I didn't feel like it's not really true of what we actually do, and that appreciative element around inspection or regulation and assurance can sometimes feel very negative and punitive. And for me, there's something about that process needs to be much more appreciative and realise that 90% plus of the time, usually people are doing a fantastic job under difficult circumstances, and sometimes that gets missed. So for me, there's that sense of staff feeling psychologically safe, but also having safe spaces. But yeah, there's a whole list of things, and there's lots of stuff now that you can Google as well, and just some really simple things about looking after yourself, and managing your time well, and taking time out, and not rushing from one thing to the other, because you shouldn't be driven by process all the time. You should be driven by what you can do at that point in time, and taking bits of time out.
Yeah, that's great. Do you want to come in there, Bridget?
No, I was just saying, I just put it in the chat. It also emphasises the need for robust supervision for staff as well, so that they can reflect and they can have that restorative time and reflective time to be able to discuss clinical cases, any challenges, the care, etc., etc.
Yeah, and you can make supervision trauma informed as well by just putting that space in there to talk about what matters. It's the what matters to you stuff. What matters to you at the moment, and how can we help you so that you feel valued as a member of the team. I think sometimes people can, and I totally get it, that you get to work, you take your coat off, you get on with your job, get your coat, you leave. And it's that kind of, and nobody's ever happy when that's the case. So it's kind of what are you responsible for, and what is your organisation that work for responsible for, and how can the two come together? And like Bridget said, that supervision can be a great space to incorporate that, rather than it feeling like it's a management supervision. Yeah. It's that sense of where's the me in all of this.
I think the importance of that, although it's putting it into a framework, if you like, a more formalised framework, but it's that importance of the supervision being a good quality supervision that is restorative for staff.
Yes, absolutely.
Yeah.
So
okay,
I'm going to move on. Sorry.
Yeah. Okay. No, I was just going to say no more questions in there. So yeah, good to go.
So I'm just going to move on to the project. So Lancashire Safeguarding Partnership Board, if that's the right term. That's the right one, isn't it? Bridget had a conversation with me, and there was some concerns from CQC inspections around some homes. There were also homes who've been doing some improvement work. So there was a mixed bag of things where people wanted a little bit more support, particularly around being least restrictive. So the project was done in a way to appreciate the work that staff were doing, whether inspection had picked up an issue and that needed to be addressed, or whether the home had already identified that as an issue and wanted some support. So AQUA, essentially, myself, came along and we worked up a bit of a package And this was the element. So taking all that foundational stuff I've talked about, these are the kind of offers. So data is extremely important in anything that you do when it comes to improvement, because if you don't have the data, what are you trying to improve? You don't know. You don't know what you don't know. That soft, cute quality improvement approach that I'll talk about in a moment, and then some learning events around the things that I've just been talking about, and then we offered coaching into those teams as well. So this is over a 6 months period. So the first thing that I asked teams to do is to better understand what's happening in their environment, what's happening on a day-to-day basis around incidents. So some of you might have seen safety crosses before, which is this safety calendar bit here, which is essentially a calendar for that month. If there's an incident and you've defined incidents as aggressive behavior or a restrictive intervention, however you define it, then on that day, on the 1st of December, a member of staff would put a cross in that box. There was an incident that day. There might have been 3 incidents that day, so I would expect 3 crosses. So what you start to see is a very quick visual representation of how many restrictive incidents have occurred. And when I talk about restrictive incidents, I also see things like the use of PRM medication as a restriction, any seclusion that might be used, any aggressive behavior, and any restrictive holds that might have occurred. So what you get then is a really quick, on the office wall, a quick visual representation of incidents that have occurred. So it just means you can get a real picture of, and a bit like buzzes, incidents can come along in 3s. So you'll suddenly get, why on the 11th were there 3 incidents? And yet the week before there was nothing. But it can really show very quickly on a calendar that there's a blip here, what's going on. And it's natural for staff to go, what's that about? And you investigate it. That's what data should be. Data tells you something and you go and check it out. So to add a bit more detail to the safety calendar, we used these heat maps, and you'll see these in your offices and homes or wherever you work. Every place has got these kind of maps, and they're really useful. If you've done a falls program, then you'll know that these are really useful for identifying when falls occur, where they occur. Are they in bedrooms? Are they in corridors? Are they in the lounge? What time did it happen? Because you might write the initials of the resident. You'll put the time there, and then you just put a bit of a cross in the box or whatever. So you might put a little bit of information. So at the end of a week, as a team, you can look at that map of the unit and say, why is there 8 falls in these 2 bedrooms? What's going on in those 2 bedrooms? So it very quickly directs you to where there are issues. What we found in these in the dementia care homes, particularly in challenging behaviour, was there were lots of issues happening on certain corridors in certain places. So we started to identify there's an opportunity to do stuff around corridors to reduce the likelihood of more incidents. So every week you would do a map. The team would look at what the issues are, go and observe what's happening, make changes, and then do a map again for another week and look again and see if that's dropped. Have the incidents dropped in terms of what's happening in that particular corridor? And it's a really simple, effective way of drawing teams to look at what is happening when you're working on a day-to-day basis. Where are these incidents occurring, and what can we do to make a subtle change? Because a lot of these things, they don't need thousands of pounds spending on them and lots of training to make a change to reduce them. And I'll take you through some examples of that in a moment. So these are the kind of, so when I do the safety crosses, I then turn them into visual graphs. So I would show these to the staff at each coaching session. So for example, I used to talk about, so you see these blips, and it goes up, down, up, down, up, down. That to me is just that's the heartbeat of any area. There are always going to be incidents. What you don't want is lots of these higher incidents, these blips that shoot up into the sky. And it was helping staff to understand what's happening with these 3 or 4, these higher incidents, and how can we reduce them down. And you'll notice here that they start to move in a downward fashion, like a ski slope. And the same again with this one, you start to see this gradual decrease. And so there's something happening here over time, because it's going down and down and down and down and down, till eventually it gets under its average red line. So this to the team is telling them, you've done something that is making a difference. You've done something that's making a change. And if you can keep that down, then you've clearly made a difference that's improved because you've got less incidents occurring. So it's a really neat visual way of looking at what's happening. And when you show staff who might not have been on that week, or they'll look at it and they'll go, oh, they'll literally say, oh, I know who that is, or I know what that's about. Because again, when you look at least restrictive practice, and particularly challenging behaviour, is that not everybody is challenging. Even on a challenging behaviour unit, not everyone is challenging. It might be 5 or 10% of people. And it's that what we call the Pareto rule, which is the 80-20 rule, that you can be working 80% of the time with only 20% of the residents that you're caring for, that most of your energy is taken up by those few. And we see this in incidents all the time, that it's generally 1 or 2 individuals who might be extremely agitated or really struggling on very complex cases. And you will see them very quickly in the data. So we tend, with data, you tend to run those what are called run charts for 12 months. And once you've run them for 12 months, you can then get a 12-month baseline. So you get your 12-month average. And then you can do what we call a statistical process chart. And then it gives you a nice average, and you can try and drop your average. So it's a nice way of saying we've definitely made a reduction. With the wards we work with, we were finding on average roughly about a 40% reduction within a 6-month period of restrictive interventions, which was great. And that echoes itself in lots of mental health inpatient areas that I've worked in, and in secure settings as well. So when we did the project, through conversations with the staff and observing what was happening in the environment, I identified 6 key areas that really stood out from the data, where incidents were happening, when they were happening. And we know, particularly in dementia care settings, personal care is by far the biggest area when incidents occur. So we could do some improvement work around personal care. Meal times is another time it can feel really chaotic and incidents happen. Observations and the quality of those observations, are they meaningful? Are they helpful? A new admission. We know that when somebody's newly admitted to somewhere, completely new, they might feel really unsettled for a few days, and that can lead to incidents. So to focus in that particular area to reduce any. So if somebody, back to that mobile phone bit, if somebody has a good experience at an admission, the likelihood is that they're going to have a good first week. Focusing on particular residents who stood out in the data. And then the last one is that environment, about what is the environment doing and how is it shaping the way in which staff and residents work together. So when I spoke with the care homes, what we found was people were sort of general sense of feeling a bit powerless. Staff were afraid to speak up in case they were wrong about something. Staff were telling us that they wanted to do things differently, but they weren't quite sure whether they're doing the right thing or not. And there was a recognition that for some of the residents, that quality of life issue was an issue because a lot of them were bored and there were not a lot of activities going on. There wasn't a really strong structure to the day. And some of the environments felt very cluttered and lots of things going on in one space. So by working with the staff through the learning and through identifying those 6 areas, we identified some potential tests of change. So I'll just give you some quick examples. So this is and it's not his real name, I called him Brian. But Brian was somebody who 60% of the incidents on one unit were Brian. And Brian was a gentleman who walked with purpose. And he walked with pride, and he walked at speed. And nobody got in his way. And he's very active. The problem that we were finding when we looked at the heat maps, why were there 60% of these incidents happening just outside Brian's door, in the corridor, and then into the lounge? So there were numerous incidents occurring, and assaults on other residents, assaults on staff, pushing over furniture. So the staff looked then at how can we change the environment. So when Brian comes out of his bedroom, there were 2 chairs there that residents would be sat in. So they moved those chairs further up the corridor. So when Brian came out of his bedroom, he didn't see any chairs there. He just saw a corridor, and then he would see the lounge, which is what he did every day, out of his bedroom straight into the lounge. But when he went to the lounge, the medicine trolley was in the way, and he'd usually push it or push a member of staff who was stood near it. So the staff decided, as well as moving the chairs, to just move the medicine trolley away from that area to the side. And then they just observed what Brian did. And Brian came out of his room, walked around the lounge, did his usual, picking things up, putting them down in different places, very happy. And he was like that all day. And there were no incidents. There were 60% of incidents were Brian. The next month, there were no incidents at all with Brian. It was 0. Brian was really happy. Brian actually got stepped down from the unit that he was in because there was no assaults with him at all. And Brian now walks with purpose, but he walks with the purpose of going around collecting all the recycling, and he works with the staff, and he loves it, and he takes the recycling out to the bin, and it's his little job, and he really likes it. So that's a real nice example of where, by looking at the data, observing Brian, the staff made some simple changes, and it made a big difference. That ain't going to work for everybody, but it worked for Brian, and that's really good. And he continues to do that to this day, as far as I'm aware. Another example is around personal care, that we found that for those of you who know the personal care tablets, that staff were using them, and they were kind of getting caught up in the technology, and the tech. So my chair has this habit of collapsing. The technology was driving practice. So everyone was driven by the tech. So every time it flagged up, you've got to do the teeth now, you've got to get them ready, you've got to do this, you've got to do that. It's pinging away, and that becomes the focus of the carer's attention rather than the patient. So one of the units I work with actually removed all the flags except for the key ones on the technology, which freed up staff to do what they needed to do, because staff knew what they needed to do. And actually what they found when they did that is that the narrative from staff that was going on the system was much more quality informed information that said, oh, Betty was really happy today. She loved having the music on, blah, 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 rather than, oh, Betty didn't let me clean her teeth. Betty didn't do this. Betty didn't do that. It was a much more appreciative feel about what does Betty want. Like, Betty doesn't want the big light on in the morning first thing. She might want a little bit of a curtain opening. Betty might want you to gently talk to her to start with, and you build it up. Some residents want to be up and at it. They want to be out of bed, dressed, they're out the door before you know it. So we have to adapt to that environment. And sometimes the technology we use doesn't adapt to the person. And we have to be the bridge between that technology and the individual to make sure it is. And that's the work that one of the units did, and that worked really, really well. And the staff were a lot happier because they didn't feel that burden of that pinging sound of constantly having to do what the tech says. So some of the impact then was that they set up some champions in one of the homes who then they set up an improvement board. So a lot of the work they were doing on changing the environment, some of the work they were doing with particular residents, or they wanted to try some activities. They put all this information up on one board in the office so all staff could see what was happening. They had regular teams huddles, and the champion would share what's happening that day or what's been happening that week. They started to review some of the planned care day tools that they had so that there were better structured days. They were encouraging staff to have ideas themselves, think outside of the box, come up with ideas, because staff are full of ideas and sometimes we just don't ask them about it. What do you think would work really well? And test it. If it doesn't work, chuck it in the bin. If it does, great, keep it. People getting more into that, how we do daily tasks and breaking that down into small steps that were more aligned to the person rather than the task itself. And that's the thing about it. It's more about the journey than the destination. Oh, I've completed the task. That's not important. How was the journey? Looking at things from the resident's point of view, putting yourself into their shoes, And again, here some staff thought that some things that their ideas that they had were a bit wacky, so they didn't mention them. So we created safe spaces for them to just say, "That's a great idea. Let's have a go. Be creative." And that was really helpful for the teams because people thought, "Oh, I've been listened to. I've got an idea. I can try it out." And the staff and teams appeared happier, more relaxed, and one of the homes noticed it had improved retention because some staff were getting that morale thing about being fed up about constantly being told it doesn't work here, this doesn't work, that doesn't work, we're not doing this right, we're being told we're not good, when actually there was fantastic stuff going on. And again, it was seen as, they see it as an ongoing part of their work. So even though I stepped away after 6 months, they felt it was really important to continue that work on. And that's really important about that sustainability. And there's a bit about staff that I'm just aware of time, so I'm going to, maybe you can read that in your own time. But overall, we saw things like step down in acuity, so there's less observations, which means you free up staff to do the things that they can be doing that are really productive. Observations can be less meaningful and a bit limiting. So you might think about, how do we be more creative around observations? That data drives practice and is really a simple thing to do and really effective. Knowing that tech can create a culture of task. So you need to think, how do we create a culture of personalized care? Focus on what drives the behavior than the behavior itself. And this to me is that trauma-informed bit. And that's much more about, oh, I can't see the thing now. What the resident's trying to communicate and why. Not that the resident is a problem. What are they telling us? And why they're saying that to us. And sometimes that can lead to, like with one gentleman who was, he worked in a prison all his life, and he went around locking and checking all the doors on a corridor. And the staff were having to walk around with his food to try and feed him, and he wasn't for having it at dinner time, and it became a problem. So we agreed that what we need to do is to, a member of staff buddy up with him, do the walk around, checking doors, checking that these doors are locked, and then going into a quiet room and him having his lunch there, and then let him be then, let him get on with his day. And what happened is the member of staff walked around with him, said, "Oh, we're ready for lunch now." And he'd done his task, he'd done what he needed to do. He then went into the quiet room, he ate his lunch, sat down, first time in months, sat down, happily ate his lunch, left the room and went for a wander around back into the day room and was fine. And was happy with the rest of his day because he'd completed what he wanted to do, and he was communicating that he's got a job to do and they need to stop stopping him from doing his job, because all that was happening was they were running around with him with food, and he was also getting aggressive to other residents because they weren't doing as they were told, because he thought they were all prisoners and they were all not in their rooms. So he thought they'd all escaped. So it was that sometimes working with, what is this person saying to us? Better understanding the environmental, how the environment impacts on care. Just the financial benefit of less incidents, increase in least restrictive practice rather than that more personalised practice. Really not wanting to get into talking about restrictive practice all the time. Be appreciative. Do the things that you'll find people really love doing. Changing the environment, so some of pretty much all the units actually changed their environments. They created more defined spaces in lounges so that there were smaller dining room areas and smaller sitting areas, so people weren't crammed in together. Corridors were repainted and adjusted so they had themes in them. People put tables outside bedrooms. One of them put a table outside a bedroom, and a gentleman who didn't go and eat with everybody else, and there were issues and concerns about his weight. And he would get quite agitated if he was trying to be put into the dining room by staff and try and walk into the dining room. He wouldn't have it. But he loved eating his food on these little chairs and tables that they put in the corridor because it was quiet. So to him, it was almost like being outside some French cafe somewhere, and he happily ate his meal, and his weight no longer became a problem because he was eating in the place that he wanted to eat. Why did he have to eat in the dining room? It doesn't. I mean, we don't in our own lives eat every day in a dining room with 30 odd other people. It just doesn't. It's not what we do. It's not normal. Increase in activities, and you really notice a reduction in levels of boredom and levels of incidents when people are much more active and there's a more structured day. Meaningful observations, again, I mentioned about staff retention increases. An reduction in safeguarding incidents. Oops. So some of the, what's that there? Yeah, just covered that. So just quickly, some of the learning for me was around, it was really important that staff had a lot of face-to-face. I think particularly in care home environments, we found that staff felt they were more engaged with that, and it takes a while to build up that trust because there's something about a history of a place. And if you've had lots of CQC visits, safeguarding visits, there's been press attention, COVID was a nightmare for people. There's still lots of trauma, and there's a culture sometimes that can feel that everything is against us, and it feels quite punitive. So I think that sense of people coming in and supporting people in an appreciative way can feel a bit odd sometimes, and it takes a bit of a while for people to build trust. But if you create those spaces in your workplaces where people feel safe to be able to come up with ideas, to talk about the things that have been distressing to them, and that be okay, that goes a long way for me to move people towards making improvements and being having a great day at work. And also that stuff about the workforce. And there's lots of challenges around workforce about when you've got lots of staff changes, how do you sustain something? And there's something about how you embed these things into the work. So sometimes having some champions or a lead around stuff is really important to give it some sustainability. And just to quickly say, before I bring it to a close, we're looking at things like, and you can look at things like promoting sensory resources yourself. You might want to train up some champions around sensory modulation to help people be able to manage themselves better. To promote trauma-informed approaches aligned to personalised care, AQUA is a great example around dementia. Promote walkarounds, which is get your staff to do a walk around and do it in the eyes of through the eyes of a resident. And the same, of course, for safeguarding leads and anybody else who comes around, just to walk around with an appreciative lens on rather than looking for problems. That sense of visual data, celebrate improvements when they're made, promote what safety looks like to families and visitors and engage families and visitors in the work, and that sense of staff wellbeing and safety orders that are really important at bringing staff together. So just quickly, we're in phase 2 of the work we've done with these homes, which is now finished, and we're sort of looking at how do we spread the learning, which part of today is about. So we currently have a steering group. We're looking at evaluating the work we've done with the homes we've worked with. We're looking to develop a bit of a care bundle package for training out of the work we've done. But it might be good for you to think about, do you link into anything that's trauma informed? And if you don't, I would recommend you go and look at that. The PSAF approach, for those of you who don't know, is the Patient Safety Incident framework, and that's the new framework. But there's stuff in there that's really interesting to look at because it's looking at incidents through a more appreciative lens and about learning rather than that punitive sort of root cause thing. Because sometimes the root cause ends up being a member of staff when actually it's not. The root cause is, well, it was a difficult day, we had lots going on, there was this, there was that, the other. There can be many causes that lead to an incident. We're looking at how do we share the learning, and today's an example again, and then seeking further opportunities to implement this approach in other settings. And I'm going to bring it to a close at that point. We've got 4 minutes or so. Are there any questions in the... I'll just stop sharing and then... Are there any questions in the box or anything before we bring it to a close?
Thanks, Paul. No, we've not had any flagged up. Has anybody got any questions that you want to ask Paul, or any sort of closing comments from yourself, Bridget, at all?
Yeah, I think the things that struck me, I mean, certainly coming from a safeguarding point of view, we definitely saw a reduction in safeguarding incidents. It was a very inclusive approach. The headline stuff that I took away was around promoting that trauma-informed approach to care delivery, and that how much that supported personalised care and reduced the number of restrictive incidents that took place, that reduction in PRM medication, Paul, as well.
Yes.
The importance of staff care as well. That really struck me from some of the conversations that we had, that staff care and inclusion, and listening to everybody at every level, because staff were still traumatized post-COVID as well, you know, so that trauma-informed approach to care delivery was also equally as important within a trauma-informed approach towards staff and engaging staff as well. So it was a fantastic piece of work. I can't say how much I enjoyed being part of it, because it created an evidence base for improvement. We were able to measure the impact, and Paul was amazing in how he engaged with the homes and included people, and it's just something that I would really lobby for people to utilise that approach.
That's great. Thank you, Bridget. Absolutely. You all put so much work into it, and the teams involved in the care homes as well. It's just amazing. I love listening to it. It's just fantastic work that you've done. We're obviously coming to a close now, so we'll share the we'll upload the this session to YouTube. If anybody wants to share it, please feel free. We've obviously got the 7-minute briefing there. If there's any references that Paul's mentioned that you need to access, that you need information from, please contact us at the business unit, and Paul's got his details on the slides as well. So any last words from you, Paul, before we let you go?
No, I think just somebody said in the chat, really, that kind of the focus being more positive, and I do think for me that's the key, that if we appreciate people and we appreciate the environments that we're going into, I just think it makes such a world of difference, because people have enough of being told that's not right, that's not the, and it's that kind of real fundamental element to almost giving people a break and being supportive in a different way. So yeah, I think that see least restrictive as that appreciative approach to a sometimes difficult issue.
Yeah, definitely. We've got a question in: where can we find out more information about the programme, recommendations and good practice? So I think you've referred to a care bundle pack and some information, so I guess that'll be coming out when it's ready.
Yeah, just some delays a bit, but yeah, there'll be something come out that supports people. And again, if some people just want a further conversation with me, and then I'm happy to have that conversation as well. And my email's on here, so if you just email me, I will get back to you. And if it means you want to do a one-to-one MS Teams thing, and I'm happy to do that. And just to say, AQUA does we are a member-based organisation, but we also, if somebody wants to pursue us for a specific piece of work, there will be a cost to that. But yeah, I'm happy to have those kind of conversations.
Great. Thank you so much, as ever, and thank you for everybody for sticking with us for this hour, and tune in for the next one tomorrow and Friday, and we'll send details out later on today on that. Thanks very much. Take care, everybody.